I will talk about castration-resistant prostate cancer. So I will not focus on castration-sensitive prostate cancer, and as you know that we have new data on lead abiraterone in this setting, but this is not the topic of today. We'll think about just the castration-resistant prostate cancer. This is my disclosure. So you know the two main things of prostate cancer. First, that this kind of tumors is hormone dependent. And this is not new, of course. And you know that there have many failures to endocrine therapy, and this is not new again because it was proposed in 15 years ago. And we have made a lot of progress since the late 90s because we have moved from prednisone alone in castration-resistant setting with 12 months of overall survival to the last study of PREVAIL from enzalutamide pre-docetaxel or the coup AA302 with more than 35 months, so 3 years. We have multiplied by a factor 3 the overall survival. And very recently, but this is castration-sensitive setting, metastatic but castration-sensitive in the CHARTED and STAMPEDE trial, where we achieve more than 5 years of overall survival. We have a lot of challenges still. First of all, as I previously said, it is obvious that we have some failure to endocrine therapy, and a lot of patients do not derive any benefits from the new androgen receptor targeted agents. And you can see in the Q301 abiraterone post-docetaxel, you see that 1/3 of the patient had a primary resistance with the progression at the first CT scan. And you see the same thing with the enzalutamide cohort in the AFFIRM trial, when 1/4 of the patients had a primary resistance. And why? One of the mechanism could be that in the same patients and in the same tumor, we can have some androgen receptor positive cells, which could be depleted by these new AR targeted agents, but we have at the same time androgen receptor negative cells. And when we put some castration, but also these new agents, we deplete the clone of androgen positive cells, but not the clone of androgen negative cells. But between this balance, we have some of the patients who have an extreme benefit from these targeted agents and others that do not derive any benefit. Of course, we have new data. This year at the ASCO meeting, we saw the Plateau Study, which is a randomized controlled trial from patients, chemo-naive metastatic CRPC patients who progress to enzalutamide. The question was, if we add abiraterone to enzalutamide, is it better to switch? Is it better over abiraterone alone? Sorry. So to add abiraterone to enzalutamide did not permit to reverse the resistance to enzalutamide. So it's the combination of the two drugs could not reverse this resistance, and this was not trivial. This is important data to know. And of course, we are making some progress about biomarkers, but still these biomarkers are not validated yet. We heard a lot of the androgen splicing variant 7, the androgen receptor. And this receptor, this splicing variant, is constitutionally active. And even if we block all steroids by abiraterone and enzalutamide, it is possible to have a resistance, as you can see here. No response for these patients under abiraterone and enzalutamide, but this variant does not predict resistance to taxane. Still, these biomarkers are not in the clinic yet, and we have to make some progress to detect, because it is detected in the CTC, and we have to go further with these biomarkers in the clinic. So the main question in 2017 is the same as in the last 5 years. Is there an optimal sequence of life-extending therapies? First, we have to keep in mind that with 6 therapies available, we have 720 different possible sequences. So obviously, we will not have opportunity to have the level 1 evidence for the optimal sequencing. Still, despite that, we have this trial, the CARD trial, sponsored by Sanofi, which is very interesting to provide a very good level of evidence. Patients with who progress under androgen receptor targeted agents, abiraterone or enzalutamide, will be randomized to cabazitaxel or to switch to another androgen receptor targeted agents. The primary endpoint will be radiographic progression-free survival, and this study is still recruiting. I think it could give some important results to choose the right treatment and to sequence them. But despite this trial ongoing, we don't have any data on prospective trial. We have only retrospective ones. You may know this systematic review of 30 retrospective studies post-docetaxel who compared the sequence, but of course this is retrospective. But you see that patients will receive sequentially two androgen receptor targeted agents seems to do worse than patients who receive chemotherapy. Of course, we have to be very cautious with this result as they were retrospective. We launched an international database involving 4 countries about patients who receive cabazitaxel after docetaxel, whatever the sequence. So we have first arm of docetaxel, cabazitaxel, and ART versus docetaxel, ART, and cabazitaxel, or docetaxel and cabazitaxel alone. And this is not, we have presented this data. Cabazitaxel with no further treatment do worse than when patients who received 3 treatments. This was not surprising, but still it gives some clues that we have patients must have to receive at least 3rd extended life therapies. We launched another database, this time with 3 drugs. Patients were included if they received 3 drugs. This is also retrospective. And we have the sequence docetaxel, caba, and ART versus docetaxel, ART, caba. Or ART first, followed by docetaxel and cabazitaxel, and you see the low number of patients, of course, because ART was very recently approved in this setting. And it seems to have no differences between the 3 sequences. So this is to reinforce the previous message that probably with 3 extended life therapies could do very well if we give them whatever the other. So what next when we have patients who receive the 3 life extending therapies? Probably we can propose to our patient to rechallenge. And we have data on docetaxel rechallenge, and we have now very recent data on cabazitaxel rechallenge. On preclinical cell lines, probably cabazitaxel works better than docetaxel in ART-resistant tumors. The problem with docetaxel is the cumulative and the neuropathy, the cumulative toxicity, and probably with the different safety profile of cabazitaxel, it is the good drugs to give. We have a trial that reinforces the message that cabazitaxel is not the same that docetaxel in terms of toxicity. This is the CABADOC phase 3 trial. It's a patient preference trial. And patients were randomized to docetaxel 4 cycles followed by cabazitaxel versus the inverse sequence, cabazitaxel followed by docetaxel. And when we ask to the patients which treatment did you prefer, 43% prefer cabazitaxel and 27% prefer docetaxel. So if we have to choose just with this question of tolerance, we have to choose cabazitaxel because it is preferred by patients. So we looked at patients who receive cabazitaxel after three other drugs. We have just 70 patients. Again, it is retrospective, but still we can see here an improved clinical benefit in a large majority of patients, 34%. 50% of patients who are stable in the rechallenge. Median progression PFS 7.8 months and 13 months, which is quite good for rechallenge in this setting in the 4th line. So we have 4 drugs. We can rechallenge if we have used these 4 drugs. we need to closely monitor progression, because if we not closely monitor this patient, probably we are going to miss the window of opportunity to give them all these drugs. And just an article to show that in the PREVAIL study of enzalutamide, on the 265 patient, chemo-naive patient who progress radiologically, about 1/3 of these patients had a non-rising PSA. So if we monitor them only by PSA, we missed 25% of patients who have radiological and objective progression. So clearly, PSA monitoring is not alone is not sufficient to monitor this patient. For these 25 patients, probably we are going to miss some subsequent treatment. And when we asked to a panel of European experts in this setting, we asked if we had to perform imaging, and 80% of them agree that we have to perform early monitoring, early radiographic monitoring, and under androgen receptor targeting agents. And probably the recommendation is to monitor them at 3 months. The first radiologic evaluation must be done at 3 months. In conclusion, prostate cancer is highly heterogeneous, and we have the coexistence of androgen-dependent and androgen-independent cells in most of the case. The survival increases clearly with number of life-extending therapies. Probably the best outcome is to use all the drugs that we have, and it is possible that to use 2 androgen receptor targeted agents sequentially is not the good idea. Probably we have to put chemotherapy between two agents. I think the window of opportunity for chemo, but for the other drugs, is the same things. It should not be missed, and we have to closely monitor these patients. To perform radiologic imaging and PSA alone is not sufficient. And I think we need a multidisciplinary approach between urologists, oncologists, and radiation oncologists to optimize the patient outcome, particularly in the first line. I think when we take the decision to give an IRT in the first line in metastatic setting, I think it is we have to discuss this patient very early to see what the evolution could be and what treatment we could give in the second and third line. And thank you for your attention.